Welcome back to the Rush Lupus Clinic and LSI educational event. We're about to start our third presentation. I wanted to review that this event is for educational and informational purposes only and serves to benefit our mission. The Lupus Society of Illinois does not provide medical advice or recommendations. This information should not substitute or replace expert medical care. Before making changes to your medical care, consult your qualified healthcare professionals familiar with your medical condition and health status. This event is being recorded and will be archived on the Lupus Society of Illinois website.
The third presentation is Dr. Jolly, and Dr. Nico is here to introduce Dr. Jolly.
So thank you for giving me the opportunity to introduce Dr. Jolly. There is not enough to say about Dr. Jolly. We're fortunate to have her as a director of the Lupus Clinic at Rush. She's a professor of medicine. She's also the program director of the Master's Clinic at Rush, and she's a program director for our fellows at Rush. So her passion specifically for lupus is contagious. She cares for lupus patients with such care that, it's kind of infectious. And she's a great professor. She's a great researcher. She's a great mentor. And I've been fortunate to work with Dr. Jolly. And without further ado, let's have Dr. Jolly give her presentation to us today about steroids in lupus.
Dr. Nico, you can turn off your camera if you like, and then Dr. Jolly, you're muted. There you go.
Yeah, I hope you can see my slides.
Yes, we can see your slides, and we can see you.
Okay, great, wonderful. So I wanted to thank everyone for being here, and to Mary, our sponsors, Lupus Society of Illinois, Dr. Cherney, Dr. Nika, and all the attendees who are here. I wanted to mention to you one of the comments and the questions that came earlier was about us working with other specialists. In fact, one of the part of developing the Rush Lupus Clinic is also to make networks with specialists that have interest in this area and have expertise in these areas. So we do have great networks with specialists in the lung diseases, the pulmonologists, the kidney disease doctors, the nephrologists, dermatology, the skin doctors, cardiology, the heart doctors, neurology, our brain doctors, gastroenterology, our stomach doctors. We do high-risk obstetrics and gynecology related to pregnancy issues. We have great hematologists, our blood doctors. We work very closely with orthopedics, psychology, physical therapy. So these are some of the advantages of being seen at a lupus clinic where these networks have already been formed and identified, and that can be utilized to your advantage. One of the things I would say is, as Dr. Nika mentioned, that the disease is more common among people of color. And whether it is African Americans or Asians, the disease is more common. And our research, as well as of others, have shown that the outcomes, how people do with their lupus, is actually worse among people of color as compared to whites. And so we also want to focus our attention on how can we make things better. And this event is one of our contribution or an effort towards that, what we call as health equities. I don't know if you're familiar with the word health equity. Health equity is the ability of two people, let's say, for example, two people going together, climbing a ladder together to get to a point A. And if I put two people of different types in there, but I start one person from middle of the ladder, it is obvious that that person will reach the top of the ladder earlier than the one who is placed at the bottom or farther away from the ladder. And so this is the example used for health equity, that if I tell you that go ahead and achieve the best healthy version of you, some people are placed unequally on this ladder, and some are placed far away from the ladder. And part of these word is used is called health disparities. Why certain people perform poorly on their health, even though they're trying to take care of their health, than some of the other people, is because of these health inequities being placed at different places along the ladder. We've done some research to show that yes, ethnic minority, socioeconomic status, all of those things can have how much is your education level, are you employed or not. Those things can have an impact on how well you do with your disease. However, as doctors, we are not able to change people's socioeconomic status, right? Or their educational status. But one thing we can do to improve these health disparities or improve people's performance on their way or their journey towards health is by making them self-aware about what is the disease, what are you dealing with, what it means, and what are the possibilities in which it can affect your life, and how can we take care of it. We as doctors try to do it all around the world. We try our best to do it. The disease is complex, time is limited, skills are limited, people's understanding is limited. But one of the important things that we are striving to do, even in this event today, is to bring you that information in a language that you can understand and relate to. We as doctors are very used to using medical terms, difficult words. We as doctors are challenged ourselves with even pronouncing some of these words. So it is very difficult, we realize from our patients, that for them to understand the message or the information we are trying to give in limited amount of time, if it is so heavy with medical language. So one of the things we are trying to do to remove health disparities and improve health equity is trying to give information to our patients at a level, in a language that is understandable, and that is something that you can understand. Because we do feel that awareness, education about what you have and what you're fighting for and what you're fighting with is very important and is the key to everything. Let's see if I can move my slide further. There. So one of the intention is to improve the awareness of our patients. So first, before we start talking about steroids, I want you to think, are you actually on steroids? We do get patients in our clinic, and this is one of the research work that we've done, is our patients think they are on steroids, but actually some of them are not on steroids. And there are patients that think that they are not on steroids, but they are actually on steroids. So it is important for you to know whether you are on steroids or not. I've given you some of the common names that can be utilized for steroids. It may be called prednisone, cortisone, prednisolone, hydrocortisone, methylprednisolone, or Medrol, or Depomedrol, or Decadron, dexamethasone, Solumedrol, a lot of different words for it. And I want you to be aware, if you're on steroids in any shape or form, that yes, I am taking steroids. What are steroids and why are they used to treat patients with lupus? I want to start this session by telling you that steroids can be life-saving in a lot of diseases for a lot of patients, but in lupus also. My intent is to educate you, make you aware about lupus and steroids, but it is not to scare you or prevent you from going on steroids if your health requires it. So steroids are a group of chemicals that are a major part of the hormones that are secreted in your body. Cortisone the word I'm using here for steroids, is related to cortisol, which is the natural steroid that is created in your body. And it is our natural anti-inflammatory hormone, the cortisol. And cortisone, the tablets or the steroid that you take, is a relative of that. The reason we use it is for multiple things. One of the important things is that it works quickly, and it works quickly to control the inflammation. And in lupus patients, we are thinking about inflammation in different parts of the body, whether it is just on the outside, on the skin. It could be in your heart, in your lungs, in your kidneys, in your blood counts. It could be in your brain. It could be in your joints. It could be in your muscles, anywhere. So this medication helps to control inflammation and works quickly. Another thing is that it helps us buy time to decide which medicine would be best suited to you, keeping in mind which other organs are involved and how severely, how badly are they affected, and gives us time till we realize that, okay, those medicines will start kicking in 4 to 6 weeks, then the dose will be built up, but the prednisone or the steroids will help us buy time in controlling that inflammation till we can decide which other medications to use for you, and if you tolerate them, and then building up that dose until they start working for you. How are steroids given? You may be receiving steroids by mouth. For example, when you get a flare of your lupus, it could be in your joints or kidneys, and this is called oral intake. It could be given by vein, like an infusion, intravenous, especially so used when lupus is affecting your kidneys, brain, or something very important organ, and at a higher activity level, a lot more stronger flare. It could be used on the surface of your body, for example, on the skin when you have active rashes from your lupus. It could be used on eyes for inflammation in the eyes. It could be used inside the ears, and that is called topical use. You may have received an injection of steroids also into the joint, where the steroid is directly deposited into the joint. Sometimes we use steroids by inhalation, where you breathe it in, and that's called an inhaler, and people with asthma or lung disease called COPD might be more familiar with it, like when you get an asthma attack or such. What are the steroid medications that are most commonly prescribed for lupus? And the word is prednisone. In US, prednisone is the medication that is used most effectively. These tablets come in variety of different doses, and your doctor may be mixing and matching certain doses at different times, bringing the dose up or down. One of the questions we get is, and a concern from a patient standpoint is, doctor, am I on a high dose of steroids? So I want you to know what we as doctors consider as high dose. Right? Being on any prednisone could be of concern to you, but you have to keep in mind what is the benefit I'm getting and what is the risk of that. So low dose we consider when the prednisone dose is less than or equal to 7.5 milligrams per day. Okay, because this is the amount that your body naturally produces inside. Medium doses between 7.5 to 30 milligrams, and high doses more than 30 milligrams. And people may use different definitions. Some people may think 20 is a high dose. Some people may think 40 is a high dose. So there's no hard cut and fast rule on this, but something to know that less than 7.5 is, or equal to 7.5 is what your body automatically makes itself. So that is considered low dose of steroids. Now, the next thing is your concern. Have I been on steroids so long? Have I been on it for such a long time? As I said before, there are reasons why people with lupus are on this medication, which may be very important reasons, life-saving reasons. But when it is used for less than 1 month of duration, we consider it as short-term use. When you are on steroids for more than 3 months, that is what we consider long-term use. And that is the place where we are concerned about, potential for side effects, and we are taking into account what is the balance between how much is the risk and how much is the benefit I'm going to gain from using these steroids in this patient. Now, do know that there are patients who will get steroids for anything between 1 month to 3 months. And so frequently for skin flares on your skin, you may be using something for few days to few weeks, and those are relatively safer to use than long-term by mouth. Let's talk about potential side effects. And I put in here harm versus risk in a different color because, again, my intent is not to scare you. There are valid reasons your doctors might be using steroids for, and it may be very important for your health. Your doctors would be taking into account what is the risk and how much is the benefit and trying to balance that out. But also here I'm covering all potential side effects, so do not get scared. This is just for educational purposes. It does not mean that you will develop all of the side effects that are listed here. Okay, these are just potential side effects. Things to know in general is that the risk of side effects is greater the higher the dose you are on and the longer time period you are usually on. Usually steroids, when they're used, they are only used after something simpler that like hydroxychloroquine or ibuprofen like medications have not worked well enough to control your disease, control the inflammation, or if a major organ is threatened from the inflammation from lupus. Your doctor will work with you to identify what is the lowest dose necessary at any point of time and what would be the shortest possible time. This may keep changing, and your doctor does not have the magic ball to predict accurately what would be your lowest dose and will it change and what is the length of time and will that change. These things keep changing, like your disease is not predictable. So your medications, your treatment has to be tailored to how your disease is doing, how your lupus is doing. So the plans with steroids, the dose and the duration may keep changing time to time. It's not a bad idea to ask your doctor if you're on prednisone, doctor, how long do you think I will be on this? Or how long do you think, doctor, I will be on this dose of prednisone? Now, keep in mind also that sometimes the steroids are also combined with other medications to reduce some of the potential side effects, and we will go over those. Some of the, starting in general, steroids can change your appearance. Lupus can change your appearance, but the use of steroids can change your appearance too. There is a word that the doctors use called moon faces, meaning your face looks like a moon. And I will show you a picture. All that means is that it looks like a round face. Our patients can, of course, gain weight with the prednisone. When your lupus is in flare, you may lose weight, but you may gain weight with the use of the prednisone. We call this, I don't like this term, a buffalo hump, but this is physically describing the change in the appearance, and I will show you a picture of that. Also, our appearance changes because the fat, where it is placed, changes. There may be a lot more fat or fat in the body around our stomach area, and it may move from our arms and legs, so you may look center heavy and not as much on your arms and legs. Now, this is something that is called moon faces. As you can see, people get a little bit plumper on their cheeks or may get a double chin. That can happen with steroids. It's one of the side effects. As you start to go down on the prednisone dose over time, it does get better. Okay. Now, this is where I am pointing to the buffalo hump. This is not as bad, but people can get that fullness with the use of the steroids. Sometimes you can get fullness right above your collarbones, and that can also happen with the prednisone use. This is just a simple picture to show you the buffalo hump, more fat on the center of the body rather than on the arms and legs. And we will talk about all the other changes in the next slide. There are some adverse effects that can happen to the skin. You can definitely get more infections in your skin. They can be different kinds of germs, as Dr. Cherney went over, bacteria, they can be fungus, they can be virus. You may have heard or developed cellulitis. You can get infection in the wounds if there are any. There can be tinea, fungal infections on your skin, something we call pityriasis versicolor infection also. Shingles can happen. In addition, use of steroids can, over time, in the long run, can cause thinning of skin, especially if you are using steroids on top of your skin. We are very careful on which kind of steroid to use and for how long, because there are different strengths of steroids to be used for skin. And we try to minimize the ones that will cause skin thinning by limiting how long and how strong and what other medications can be used also on skin to control your rashes. One may see little red splotches or purple splotches develop under the skin. Your skin may bleed easy and it may heal slowly, especially in the areas that are exposed to sun. There can be stretch marks. We frequently get people saying, like, I'm not pregnant, but I have all these pregnancy marks developing around my arms or my belly. But it could be related to the prednisone use. Also, with the weight gain, you can get stretch marks. Now, definitely, steroids can increase acne. It can increase growth of hair on the face, as well as cause loss of hair in some other areas, like on your head. Here is one of the pictures. Again, you can see the round moon faces here in this picture. There is some redness going on here, but that is just showing you moon faces. Some acne, especially in the younger people, you can get that. Acne in the chest area. These are the stretch marks. And this is skin thinning. And some of the purplish, bleeding sort of marks on the body. I also want to tell you about, have you be very careful about using the steroids on your body, on the skin. We often think that steroids don't have that much side effect when we use it on our skin, and because we may feel that it is helping our rashes, we may continue to overuse it sometimes, or sometimes because our doctors have not probably told you to stop using that once the rash has cleared and use something else instead. When we use certain kinds of steroids for the long term, our face can develop a rash right from the steroids, and it is so dependent. So the moment you stop the steroid, the rash will come up. So be aware about that there is something about overdoing the steroids too. Once your rash is better, you should be switched to less stronger steroid creams or to something completely different on the skin. Steroids can sometimes leave difference in color in your skin. If you see in this picture, there is a lighter spot, there is some darker spots, and you can see the hair on the face too, right? Now, some of this lighter skin, darker skin can happen with healing of the rashes from your lupus. It does not necessarily have to be from steroids, but I want you to be aware that steroids, if not used carefully under the guidance of your doctor or your dermatologist, can cause pigment changes in your skin. This is a picture again of the rashes that people who are using steroid creams for long can get. And these are actually not rashes from the lupus, but from fungal infections in your skin. And people may confuse them with having their lupus worsened. Let's talk about the eyes. I don't know if you've heard about glaucoma. Glaucoma is when the pressure inside your eyes is increased. and it can cause redness and pain in your eyes. So use of steroids can be associated with that, as well as it can be associated with cataract development over the time. Now, cataracts are normal that can develop with aging anyways, but steroids can hasten that process. Let's talk about the circulatory system, the vascular system. Use of steroids over time can elevate your blood pressure. It can contribute to developing heart disease, also towards heart attack. It can contribute towards developing similar disease in your brain, which can be causing stroke, called brain attack. It can contribute to you developing high cholesterol. It can contribute to increasing your blood sugars or diabetes. In your stomach and gastrointestinal tract, use of steroids, especially if taken by mouth, can cause heartburn, gastritis, and ulcers in your stomach. And this is especially complicated if you're also taking non-steroidal medications like ibuprofen, naproxen, and such. So those two medicines together are very strong on your stomach, the lining of your stomach. It can cause inflammation in pancreas. It can cause fatty liver, which can be seen as a bump in your blood tests for liver, as well as it can cause some imbalance in the fluid. People who are taking steroids can feel some fluid retention, leg swelling, and all that. And sometimes with use of prednisone, there may be low potassium that can also add to general weakness. Now, those are tests, those potassium and sodium, all those tests are routinely done while people are following you for your lupus. So don't be worried. If your potassium is low, your doctor will let you know. Let's talk about the reproductive system. It can be associated with irregular periods. In pregnancy, remember that patients may need to be on steroids in some cases, whether it is for their own disease being active or being used for helping the developing baby. Now, if you're talking about prednisone, it does not cross over to the baby. So it can be safely used during pregnancy. If we are trying to treat the developing baby, then we use a different kind of a steroid. Some of the side effects are that you can develop preterm labor. It can be managed if it's not too early. Of course, it can also cause a large baby. I'm using simpler terms here, or a small for term baby is the word. Large baby is because it could be associated with diabetes in the mother or the high blood sugars. Small baby could be also related to the fact that the mother's lupus may be active, and that is why she's on prednisone. But keep in mind that it may be very important despite some of the concerns around the pregnancy. While you're using prednisone, you can continue to breastfeed, but the baby needs to be monitored if the patient is on more than 40 milligrams dose of prednisone. So you all may have experienced or heard about the effects of prednisone on your muscles and joints. Definitely big risk of osteoporosis if you're on long-term steroids. We are very concerned about osteoporosis because of the risk of the fractures. And Dr. Nika mentioned this osteonecrosis of the joint, especially in the hip, and I will show you a picture. And what that means is that the circulation to a certain part of your bone that is next to the joint is affected, and so that part of or a piece of bone dies. And all that causes an extreme amount of pain, and especially in weight-bearing joints that are important when you're standing and walking. It could lead to a lot of pain with the weight bearing, and it may cause a destruction of that weakened bone. Long-term steroids can also cause weakness in the muscles, and it can be associated with rupture of tendons. Keep in mind, rupture of tendons can occur with certain antibiotics also in patients with, generally in anyone, there are certain antibiotics that can be associated with that. We sometimes do see tendon ruptures in patients with lupus, irrespective of steroid use. Now, in pediatric population, in children, when they are getting steroids, it may affect their height, growth restriction, how their bones are still forming, so it may affect their growth. So this is a picture of the avascular necrosis. This is our hip joint, and this is the normal blood vessels going. And when you get avascular necrosis, these little blood vessels may narrow down and cause destruction or death of this piece of the bone. Over time, it may cause damage to your bone itself, and may need surgery and pain medications to treat that. Now, when you're on prednisone, some of you might have felt, am I going crazy? Is my mood going crazy? What is happening to me? You may feel that my sleep is being affected, and definitely steroids can affect your nervous system. It can cause mood changes. It can give you that extra energy, and that is one of the reasons why some of our patients don't want to get off of steroids, because they feel that, oh, it's giving them that sense of well-being and feeling better. So why get off of it? But then we have to keep in mind the potential for side effects. It can cause a little bit of memory loss, but more importantly, sleep disturbance. But dosing your prednisone around in such a way that you don't take it close to bedtime may help you with that. In some people on high doses of steroids, it may cause some shakiness and tremors. I have mentioned this previously, that prednisone can increase your blood sugars, and in patients who are diabetics, it can worsen your diabetic control, and there can be a condition of excessive steroids that naturally also occurs, so it can give you those, and that moon phases and buffalo humps are part of that. Now, it can have an effect on our immune response, that sometimes patients who are on high doses or even medium doses of steroids will notice that their blood counts, especially the white count, is up. And that is usually when our patients will send us a message, and we'll let them know, this is because you are on prednisone, but this is something to be worried about. There's a reason you are on it. But being on steroids also impairs your immune system, like with any of the other immune suppressing medications. So you may be more susceptible to infections of different variety, or have a more greater severity of certain infections if you get that. Shingles is one of those. When you're on steroids, especially medium to high dose, it may reduce the response to a vaccine that you may be getting. So do talk to your doctors, or your doctors may be telling you how to time your vaccine around your medications. And this is not true just of steroids. It is true of a lot of medicines that you take for your lupus that suppress your immune system. Dr. Cherney went over this already. In general, we don't recommend our patients using live vaccines. Especially so if they are on 20 milligrams of prednisone or more. We anyways prefer dead vaccines in our patients with lupus, something to keep in mind always on that. What can I do to stay as healthy as possible while taking my steroid medications? As I mentioned, you may need to be on steroids because of your health, because of your lupus, but what are the things you can do? Be educated about it, and that is one of the missions today, so that you're aware and you can have an informed discussion with your doctors and care providers about your concerns. And keeping ahead of the game for the doctors is important, but keeping ahead of the game is important for the patients and their caregivers too. So be aware, be knowledgeable. Also communicate your concerns, your symptoms of what you're developing with your provider, so that you can both make a common decision, arriving to a decision together as to what is required, why it is required, and what it can do and what it can't do. Does it work for both of you? More importantly, understand the plan. If somebody is putting you on steroids, time to time visit with them. Doc, what do you think? How long will I be on this? Will I be on the same dose? And how long will I be on? Will I need to use a different medication? So understand the plan and revisit that plan time to time. And I'm say diet here, maybe I should say nutrition. Anyone needs a good, whatever you put in your body should be good, right? Especially so in patients with lupus. Especially so if you are on prednisone. Prednisone makes you hungry. It kind of boosts your appetite. Okay, there is the word boost I used that Dr. Cherney was using. But boosting your diet may make you gain weight, and that may make your joints hurt even more. So keeping in mind that it is the medication that is making me hungry, and what are the kinds of foods I must avoid is important. So make a conscious effort to not be around high caloric foods or unhealthy foods like French fries or chocolates and things like that. I'm giving you the foods that I find unhealthy that I really like, but look at those. If it is available right next to you and you feel an urge to snack, you will snack on those. But if they are not at home, but instead the snacks you have available are more the kind of snacks that make you chew and fill your stomach, give that sensation of filling up your stomach, will send a signal to your brain that, okay, yes, I'm hungry, I need to eat, but I'm chewing, I'm eating, and my stomach is distended, so okay, I'm done. But it will not add a lot of calories. It will add fiber, which will be good for you for a variety of reasons. So we say grazing kinds of foods, salads, fruits with high fiber, those kinds of things are good to do. Okay. In your diet, you should also take into account that you're taking adequate calcium and vitamin D, and that your diet is well balanced. From the steroid side effect of osteoporosis, as I already mentioned, calcium and vitamin D, have attention to that. Exercise, remain active, don't smoke. Smoking is not good in patients who are taking steroids, but in general for lupus, smoking is not good. It's not good in general for anybody because of the health things associated with it. Get yourself tested if you're on long-term steroids for having weak bones or not. Discuss your plans for steroids with your doctors. And if you do have osteoporosis or meet the criteria for treatment for osteoporosis, discuss with your physician and what are those treatments and if you need to go on those. Already mentioned, staying active is good for the bones, but it is good for your joints and muscles as well as for your mood. So doing that is a win-win situation anyways. I understand patients who are feeling fatigued, have joint pains, muscle pains, may not want to do it, but there is some level of activity that I think is feasible at some point of time for patients. Avoid smoking. As I mentioned, it is generally not good, and we know that heart attacks are increased in our patients with lupus, so you don't want to add to that risk. Also, we know smoking can flare lupus, and flares with lupus frequently are associated with going on steroids, so that is something to avoid. From infection standpoint, we started from our session today from vaccines. Follow all safe precautions, keeping your distance, hand washing, usual kind of things to prevent infections as you're doing with COVID with the masks, vaccines, and then discussing your plans for steroids as soon as possible, going to the lowest possible dose, and when at the lowest possible dose, discuss with your doctor about when can you get off of those medications. You need eye exams when you're on steroids, long-term steroids, because we talked about glaucoma and cataracts. Also, steroids can contribute to blood pressure and your diabetes and cholesterol, so you need eye exams for that. Also, patients may be on Plaquenil, and you need eye exams for that. One thing important I want you to know is to not abruptly stop taking steroids. And this can happen from a lot of reasons. A patient may want to do it, or patient runs out of the medications. I want you to know that stopping the medication suddenly, depending on what dose and how long you are on, can be life-threatening. And that is because your body gets used to the prednisone coming from outside and stops or reduces its natural production of the steroids. So it is important to reduce the dose slowly so that your internal production of steroids can resume on its own. And it is for this reason that I tell you that you should be conscious about getting refills. Make sure you have enough medication before you run out. If there are holidays coming, this, that, be proactive. Ask for a refill, when you are at your last refill already. So be proactive on that. Are there other drugs that I may take while I'm taking steroids to reduce some of the side effects? And yes, there are patients who are prescribed antibiotics when they are on 20 milligrams of prednisone daily or more to prevent a certain specific kind of pneumonia. And I suggest that. Also, Dr. Cherney mentioned the pneumonia vaccines. Those are very important. You may be put on some medications like Protonix or Pepcid if you're getting heartburns or have peptic ulcer disease. If you have osteoporosis, you may be put on some medications for that. If you have high cholesterol, you may be put on medicine for that. And these can be associated with steroids too. Now, if you fall sick for some reason and need to be hospitalized or are undergoing a surgery and you've been on steroids, your body's natural need for the steroids is increased in these situations. So what we ask our patients is to let their doctors know what they are taking. And this is where I started. You should know if you're taking steroids so that your doctors can do the appropriate right thing by you, because you may need a tiny bump in the steroids for 48 to 72 hours if you're undergoing a procedure or are hospitalized for some reason. Now, when the doctors are reducing the prednisone dose, there can be some kind of symptoms you may experience, and that may be because the tapering or the withdrawal is being done too quickly for your body, or your body is not able to handle it at that pace. So I want you to know what those symptoms are. I wanted to mention here that tapering of the steroids is not necessary, again, if you are on short-term steroids, okay? If you are on steroids for longer duration, then it needs to be done slowly. And some of the side effects may seem like your lupus is acting up or you're developing flu-like symptoms. You may have low-grade fever. Sometimes blood pressure can drop with that. You may feel tired, headache, muscle ache, joint pain, flu-like symptoms in general. You may feel like that. So do talk to your doctor about that, especially if your dose is being reduced. The things to be monitored when you are being treated for steroids include a careful monitoring of your blood pressure, your body weight, your blood sugar, as well as, try to avoid using the non-steroidal ibuprofen sort of medications if possible when you're taking the prednisone. Now, what are doctors and researchers doing? I want you to be aware from our side what we are doing to prevent these kinds of side effects or the use of steroids. We are trying to educate ourselves in, do we really need to use steroids? How quickly can we taper? How soon can we taper? How to taper? What are the things we can use? So we continually try to educate ourselves with the latest literature, latest research. We try to educate you so that you and us, we can make a team to get to the decisions, what is best for your health. There are also now research being done to study if there are any regimens where we can treat patients without any steroids, or just give them for a very, very short time initially and then quickly remove it. So there are trials going on that, and we are waiting for those trials and results to see if it is safe and effective to do some of these less steroid regimens or no steroid regimens. So I feel that awareness is power, and the greater your awareness, the greater your power. And I want to empower each and every one of you with information so we can address it all together. With that, I would like to thank you, and I'm happy to take questions.
Great. Thank you so much, Dr. Jolly. That was great. We do have some questions, so hold on to your hat here. We actually got like maybe 4 or 5, so let me just make sure I don't miss anything. So here's a good one. I have been on steroids, prednisone, for many years. In May, I was diagnosed with drug-induced adrenal insufficiency. So why does this happen? And what is the other alternative to prednisone when you can't take any other medications to treat lupus because you are allergic to them? And this is a question from Yolanda.
Yes, that is a good question, and I, briefly alluded to that. So our body gets used to the steroids that are coming from outside, and so adrenal is the gland that creates our internal hormone, which is a cousin of this prednisone. So it gets sluggish. It knows that my steroids is coming from outside. Why do I need to work this hard to create my own steroid? So what happens is there is a dependence of that nature. So in these situations, you will need some steroids. You will need a consultation with an endocrinologist. You would need some special testing to get diagnosed for this and work closely with them to see what are the best regimens that would support your adrenal insufficiency, because that does need to be supported and treated, and see if you are able to get off the steroids. But the steroids that they may want to use may be slightly different to support different different functions of the steroids, of the natural steroids in your body. So working closely with an endocrinologist and your rheumatologist is the key to that. If you can't use any steroids at all, talk to your doctor. There may be certain other medications, like we use methotrexate, azathioprine. Maybe you need a non-steroidal medication, ibuprofen or something, to help you by that time till something else happens. But there can be some management plans that can be made around your specific case. You need to discuss very specifically with your rheumatologist and involve an endocrinologist.
Okay, great. Another question, this one's from Harlany. Please review info on the swelling in the shoulders, the buffalo hump, which is not a pleasant term.
I know it is not a pleasant term, and in medicine, unfortunately, we have a lot of pleasant terms, unpleasant terms. Think of us, we look at pictures of stomach and call it watermelon stomach and cranberry something, and it ruins certain things for us. Yes, it's not a pleasant term for anyone to be compared with that, but there is a bit of a fat collection, as I mentioned, in certain areas of the body when people are on long-term steroids, especially high-dose steroids, and the back of the neck is one of the area where it can collect, besides the cheeks, besides your belly area. So those are some of the areas when it is at the back of the neck, that is what it is called, buffalo hump. But as I mentioned, right above your collarbones, there can be some soft tissue fullness also, and that can also happen. Luckily, as you start to go down on the medications, as your disease is well controlled and other medications take control of your condition, these all things resolve. I will mention that there are people who have this not even being on steroids or having lupus, and you have to, at all points of time, take a balanced approach. What is at risk? My health is at risk, or is this extra small tissue fat at my neck more important? I know it is. I'm not undermining how one may feel with this, because it does change your appearance, but remember, it is temporary. Everything has to be prioritized. You need to be able to survive to think that this matters to me. Okay, so prioritize. It is important, but you're on for a reason on steroids, so keep that in mind.
That's an excellent point. Just in general, it feels like lupus treatments, although they're getting so much better, and we'll talk about that probably in the panel, but that there's always this give and take. You always have to look at that. And we've talked to so many people who've hated steroids and they've stopped them, and it's so dangerous to do, right?
Yes, absolutely. Very bad for the patients. And yes, it is very anxiety provoking for the doctors too, because we know what is at risk here. So that is why I made a mention about refills. Never have less than one refill on your prescription written. Always be proactive. If you've been a patient, there are delays in getting refills, whether it is from the pharmacy, getting the message, or the doctor, or the holidays, or whatever. Always, if you're on prednisone, at least have one refill at all times available on your prescription.
Yeah. Here's a question from Mari. What's a high or a low dose of prednisone? I know you talked about that, but maybe just a little bit more.
Yes, so Mari, less than 7.5 milligrams or equal to 7.5 milligrams of prednisone daily. And the reason we say low is because that is the amount your body naturally makes. So that is low dose. Definition of high dose is very varied. For us rheumatologists, we think at 40 milligrams daily, but people would vary and tell you maybe 30 milligrams it is. That cutoff is a little bit arbitrary. But I would say anywhere between 7.5 or 10 to 20 or 30 is medium dose.
Okay. Another question from Mari. What test should we get for our eyes while being on lupus meds and or steroids? Are there different types of tests?
So when you go to the ophthalmologist, the eye doctor, not an optometrist, this is very important for you. Even if you're not on steroids and just on Plaquenil or hydroxychloroquine, you need to see an eye doctor, not an optometrist, because you will not get the appropriate attention and care you need from the optometrist, okay? If you need just glasses, you can go to the optometrist. So the ophthalmologist, the eye doctor, is going to take history from you, find out what your risks are, what medicines you are on, blood pressure, diabetes, cholesterol, glaucoma, what medicines you are on, and will do the right test. Most likely, they will dilate your eyes and then look at the back of your eye. We call it the retina. And that is where they're looking for any changes related to blood pressure, cholesterol, diabetes. When you are on steroids, the doctor will look at your lens to see if there is cataract. They will measure the pressure of your eye, that little whiff of air that comes if you haven't ever gotten this test. It's a very gentle whiff of air that comes and measures the pressure of your eye. That is very important. And then if you're on Plaquenil, the test is called OCT. You should know if you're on Plaquenil, did you get OCT test or not?
That's excellent. And another one from Mari, is gabapentin and ibuprofen the same thing?
No, they're not. Ibuprofen, naproxen are non-steroidal anti-inflammatory medicines. And gabapentin is a medication used for nerve pain. It can be used for a lot of different indications, but it is a different category of medicine.
Okay. Here's a question from Kira. Why do I have fat pockets in the back of my knees? Is that one of the steroid spots?
Mary, I'm not on steroids and I have fat pockets, not just behind my knees, in a lot of different places. Okay.
Don't get started on that one. Yeah.
So I don't know, Kira, what your situation is, but that is something I cannot comment on. Usually that is not the area specifically. As I mentioned, legs and arms don't get it as much. It is generally abdomen, face, back of your neck, and the shoulder area.
Sounds great. All right. So of your patients, this is just sort of a colloquial, it doesn't have to be scientific, but about how many of them are on steroids and how many of them are on long-term steroids?
Oh God, that is very difficult to answer. It depends on the doctors that you're seeing in Lupus Clinic, because generally we see patients that have, you know, difficult to treat lupus, long-term lupus side effects. We may have more number of patients that are on steroids at any given point of time as compared to a general rheumatologist clinic. Mm-hmm. We may have higher number of people getting IV and high doses of steroids, but if I had to take a guess, I would guess somewhere 30 to 40% of our patients might be on some dose of steroids. Mm-hmm. But I will say this, that we did a study, a research study, and Dr. Nika was part of that, where we compared the quality of care that lupus patients got when they were seen in a lupus clinic versus a general rheumatology clinic, and this is all within one center. So they're educated the same way and everything, and we found that less number of patients in the lupus clinic treated patients were on steroids, on lesser doses of steroids, despite their disease being more active.
So that's pretty interesting. it would be really interesting to do that on a large scale. I don't know, did you say that was at Rush, or you
Yes,
read
it was at Rush, and the reason we feel is there is a phenomenon called patient volume relationship. Okay, volume outcome relationship. So volume is the number of certain thing that you see. If we see a large volume of lupus patients, we feel that is tied to the outcomes, how the patients do, because those doctors in and out are focusing only on lupus and are reading all the literature, are aware of all the side effects, are more proactive in having these discussions or putting other medications early on or reducing the dose of steroids as soon as possible.
Yeah.
So, but again, it needs to be replicated in a larger study. It has its limitations, but I do feel that the places that have access to lupus specific interest doctors, because you see this day in and day out, you're more in tune with, okay, does this patient have this vaccine, this thing done, eye exam done? So the preventive things are all looked at and reviewed quite frequently.
I think it also, just to me, a layperson, sort of indicates how you don't want people to be on steroids long term, and that you're familiar with the signs of when it is safe to remove them from steroids, right? So there's a lot of value in seeing someone who sees lupus a lot.
Right, and it's not to say that other rheumatologists are not. I want to be fair. Everyone is aware of it. It is just that the patient population we see because of lupus, we are looking at very young people to all different ages, and we are very aware of different effects of lupus and the medications on a lot of things, including fertility and things. So we are proactively trying to reduce things as soon as possible or feasible, so that patients don't develop long-term damage or side effects. So prevention is one way to do. In our clinic, we have a grid we use of a checkbox. Every time a patient comes in, we do checkbox. Has this been offered? Has this been done? Has this been addressed? So we look at all that, and I can tell you that that takes extra time and effort. It is not rewarded through insurance or payments or RVUs, but that is our dedication to what we are doing to the cause, and because we care about it.
Right, and yeah, the patients are the focus for sure at the Lupus Clinic. So with the new drugs, and we'll talk more about the new drugs in the panel discussion, I'm sure, but any of the new drugs, are they going to have an impact on the steroid use?
Yes, and so that is what I was mentioning, that there are not the currently approved ones, but we are studying certain regimens for lupus nephritis and otherwise, how quickly lowest dose maybe we can give right for 1 week and then quickly taper it off and then continue with other medications. How do those patients compare with patients where they're doing the usual regimen that we do right now, but we are not there yet. But one of the trial I mentioned, the Reproductive, was done in England and showed very promising results. Right now it is being studied further, and there are a lot of studies being done in this area, how we can address a steroid-free or low steroid treatment regimens for our patients. And we are going in that direction. We're going in that direction, but we are not there yet.
Right. But yeah, coming soon to a doctor's office near you, kind of a thing, right?
Exactly.
Yeah. All right. Well, these are the questions for now for this presentation. So we're a couple minutes ahead, but we're going to take a break, and then we'll come back in a few minutes and we'll follow up with the panel discussion. So thank you so much for the presentation. It was wonderful.